Okay. Welcome, everyone. Just going to give some time for people to join. And for those of you who have joined already, thank you for joining us. There is a poll up, so please do complete it so we can get to know who you are. Okay. All right. Well, thank you everyone for joining us today. And welcome to our IAS-USA webinar on hepatitis C elimination. I'll be your moderator. My name is Kara Chu. I am an infectious diseases faculty member. I do adult infectious diseases at the University of California, Los Angeles. And our speaker today is Dr. David Wyles, Chief of the Division of Infectious Diseases at Denver Health Medical Center. So we have some introductory slides before we get into our talk. Here are disclosures for the IAS-USA content on the web board. And disclosures for Dr. Wyles, for me, and the peer reviewers are listed here. And the IAS-USA designates this activity for a maximum of 1.25 CME credits. And the webinar is also approved for 1.25 hours of ABIM MOC points, nursing, pharmacy, and pharmacotherapy credits. And generous support for this activity has been received from the contributors listed here. Just so you know, the on-demand recording and slides will be available or should be available within 24 hours. And if you haven't yet completed the poll questions, please do so. During the talk, you can submit questions using the Q&A button. Please use the Q&A button and not the chat, though the chat will be open for discussion. We will take questions after Dr. Wyles' presentation and address as many as we can. We did receive some questions submitted in advance, and I think Dr. Wyles will be covering a lot of those in his talk. Okay, so just to introduce again our speaker, Dr. Wyles. He's professor of medicine at the University of Colorado and chief of the Division of Infectious Diseases at Denver Health Medical Center. Also recent past co-chair of the AASLD IDSA HCV guidelines. So we're really lucky to have him with us today to bring us up to speed on where we are with Hep C elimination globally and in the US and strategies to achieve elimination. So David, take it away.
Great. Thanks so much, Kara, and I'd like to thank the IAS-USA for this opportunity to talk to you all about hepatitis C elimination and give an update about how things are going. So as you've already heard about my disclosures, they're listed here, nothing to disclose. So we'll start with our objectives. So I want to first describe the current state of hepatitis C virus elimination and progress in the United States and across the globe. Try to identify some of the barriers to hepatitis C elimination, particularly in the US at various levels of the care cascade, and then get into some approaches that we can hopefully use to improve hepatitis C treatment delivery and facilitate elimination. Before that, we're going to start with some pre-test questions. Here's the first one. What percentage of hepatitis C incidence decrease is the target for elimination by 2030 set out in 2016 by the WHO mandate? You can see your options here, 50%, 80%, 90%, or 100%. Just a few more minutes or a few more seconds here. Okay. And let's go on to the next question, hopefully. Let's see here. There we go. So question number 2, hepatitis C virus reinfection rates after successful direct-acting antiviral or DAA therapy are highest in which of the following groups? Persons with cirrhosis, persons who inject drugs on opiate agonist therapy, men with HIV who have sex with men, or cisgender women who have HIV. Again, we're looking for the group with the highest reinfection rate here. Okay. And so we'll come back to these questions at the end, and hopefully in the interim, we'll give you some information to help you answer it. Right. So I want to start off by kind of just going through some definitions and saying what we mean when we say hepatitis C elimination or elimination in general. So the definition of elimination typically is based on a decrease in disease incidence. Classically, that would be the disease incidence going to 0. So no new cases of any given disease or infection. You can take different criteria, and we'll talk about what the criteria are for hepatitis C, but it doesn't necessarily need to be disease incidence going to 0. And then in the cases of elimination, we often talk about geographically defined areas. So we could be talking about elimination within a country or a region across the globe, not necessarily across the whole world. And then what often comes up with hepatitis C specifically is this concept of micro-elimination. Really, that's just taking whatever criteria you've set, say a decrease in incidence of 80 or 90%, and applying it to a very specific either population, say persons living with HIV, or maybe even MSM with HIV. And then you could even take that down further, as we'll talk about, and maybe talk about it in the case of a country or a city, even as we'll see some of the case studies. The other contrast is to eradication, which means complete elimination of an infection across the globe. The classic instance there is smallpox. And so we're not talking about hepatitis C eradication, we're talking about elimination. And then as we think about elimination, what are some of the aspects of an infectious disease? And we'll highlight the aspects of hepatitis C here that lend to discussions or considerations of elimination. First of all, you either have to have a disease that is easily identifiable, whether that be by symptoms or clinically, or have an effective screening test. And in the case of Hep C, we don't have the former. We don't really have, it's not identifiable symptomatically or clinically. In fact, most hepatitis C infections are relatively clinically silent. So then we need a good and effective screening test. And we have those, antibody tests and RNA tests, but the way we implement those have impacts on how well we can progress on elimination, and we'll discuss that. You also need to have curable therapy or an effective vaccine. And again, I'll highlight these later on, but we have excellent therapies now for hepatitis C. There are maybe issues around access and how available they are, but we have great therapies that can cure the disease or the infection. What we don't have is a vaccine, and we'll come back to this as well, which is one of the issues that poses a problem with hepatitis C elimination. And then you also need to have an infectious agent where there's not an animal or environmental reservoir that you would also need to address, or it certainly helps if you don't have that. And that is, we do not have any of those reservoirs with hepatitis C. So a number of favorable factors for hepatitis C elimination. So what are the WHO global hepatitis elimination strategies? And again, these were set out in a report published in 2016, and kind of all these criteria refer to considering 2015 as kind of the baseline. So what has been set out here is for diagnosing 90% of persons living with hepatitis C across the globe. I've added in this dotted line here, which was based on the 2024 WHO analysis, kind of saying where we are at the moment. And roughly 36%, it's estimated, of persons living with hepatitis C across the globe have been diagnosed so far. So we still have a ways to go. In terms of getting those persons then treated, the goal is 80% of those treated by 2030. And again, this dotted line indicates where the most recent WHO analysis estimated at about 20% of persons globally have been treated for hepatitis C of those with viremia. Next, we come to incidence, and this is really kind of the linchpin of hepatitis C elimination, and the WHO goal is an 80% reduction in incidence or new hepatitis C infections. It's a little confusing sometimes because the overall strategy encompassed hepatitis B and hepatitis C, and they said overall they want a 90% decrease in incidence of viral hepatitis, but that was split between 95% reduction for hepatitis B and an 80% reduction for hepatitis C to arrive at that average of 90%. So again, for hepatitis C, it's an 80% reduction in incidence. And then really, if you do these other things, what we hope would follow would be a reduction or a decrease in mortality related to hepatitis C. And what the goal they set out here was a 65% reduction in mortality. So where do we stand right now globally with the prevalence of hepatitis C? And again, I'll emphasize that this is prevalence. So this is the number of folks living right now with active hepatitis C infection. And you can see here, this is from the Polaris Observatory and the Center for Disease Analysis. And they did an analysis that encompassed kind of numbers in 2022, where they said about 0.7% of persons living across the globe are infected with hepatitis C. Again, this is viremic infections. That translated to 57 million persons. And then I included this here, which just gives you a rundown of where most of these folks are. And you can see Pakistan leading the way with the most viremic infections. The United States further down, but fifth, with somewhere between 2 to 4 million. And we'll talk a little bit more about that. We'll go into a deeper dive about the current state of hepatitis C in the United States. So the other way to kind of, I think, useful to break this down is see how this is evolving over time. And so again, from the Center for Disease Analysis and the Polaris Observatory, they kind of did the calculus by how they came up with 57 million. And this started in 2015. Again, the baseline for the WHO elimination guidelines and kind of what they're comparing to said at that point it was 63 million. Then you have new infections. The estimate right now is about 1 million new infections with hepatitis C every year. So that brings you up a little further. But then at the same time, you have people being treated for their hepatitis C and being cured. So that brings your number back down. In addition, every year, folks are dying either from viral hepatitis, so cirrhosis, liver cancer related to hepatitis, or others are dying of other causes, but also had hepatitis C. And so again, those hepatitis C infections are kind of removed from that number. And that was kind of at the end of 2019, beginning of 2020, how they came to their number of 57 million roughly. And then I kind of extrapolated that further because we do have data from WHO going out to 2022 that was published in 2024. And so if you take that baseline 57 million here and say, again, about 1 million new infections every year, you add 3 million. If then you look at deaths, there are about 1.3 million deaths estimated a year due to combined viral hepatitis B and C. 17% of those due to C, so that would be at least another 70,000 deaths. But then again, there are other folks who end up dying with hepatitis C, but not related to it, that brings that down further. So that brings you down. And then if you look at additional treatments, so the WHO has estimated roughly since the introduction of DAAs, there's been about 12 to 13 million people treated for hepatitis C. And so if you take the 3 years, including 2022, 21, and 22, somewhere around an additional 3.8 million. And that's how they kind of arrived at their current estimate of about 50 million viremic infections across the globe. So we talked about the WHO plan and kind of where we think the state of hepatitis C is across the globe right now. I want to start shifting a little bit to look at the United States specifically. Shortly after the WHO came out with their elimination kind of guidance, the National Academy of Sciences came out with an elimination plan in 2017 for the United States. And I've just kind of set a high-level diagram kind of summarizing what was in that. It's a 300-page document if you want to go through it. But it starts with federal oversight, the CDC working with state and local health departments to kind of work on refining, if needed, case definitions and how reporting is done, and then to work with those local jurisdictions to get updated incidence and prevalence numbers and studies done. So that's kind of the background. And then what they laid out were kind of 3 different spheres of where things needed to be done or changed to make progress on elimination in the United States. This left side here that I'm highlighting really is the actual care of hepatitis C. So how do you diagnose, test, prevent new infections? And within that, it was expansion of syringe services programs and opiate agonist therapy treatments in the prevention sphere. We know that's really a necessary component. We can't just treat our way out of this, particularly for vulnerable or high-risk populations. It needs to be combined with preventative measures. And again, we don't have a vaccine, so it really relies on other prevention strategies. You need to expand the testing and capacity, so getting out of the clinics into the community to reach other folks and have new testing algorithms, and we'll touch on those. And then really a fundamental component is unrestricted direct-acting antiviral or treatment access. We are not quite there. We've made a lot of progress, and I'll relay those as well. Then how do we deliver all this? So expanding service delivery. It touched on a lot of different things, but building capacity in primary care. Essentially developing a program to help fund hepatitis C care, analogous to the Ryan White programs we have for persons living with HIV. That has not happened to this point. And then in carceral settings or justice-involved persons really having comprehensive care and treatment. We've seen kind of movement in that direction. There are periods where the testing is available, but treatment is available, but it's certainly not universal in carceral settings that you can receive comprehensive hepatitis C care and treatment at this point. And then, as always, money is the other big thing. How do we fund all this? One of the things they outlined that I'm just going to highlight here is that really the federal government doing kind of nationwide negotiations on purchasing and having availability of DAAs, which feeds back over into this unrestricted access. So where we saw the global picture, but where a little more detailed look at where we are with hepatitis C right now in the United States. So this is some updated data from the most recent NHANES survey that covered the period of 2017 to 2020, showing an overall prevalence of about 0.9% of viremic infections. That translates into roughly 2.3 million persons estimated to be viremic and living with hepatitis C. In terms of some risk factors, if we look at it, more men than women tend to be infected. If you look at age groups, it still predominates in the older groups. I think this is an interesting finding of the study because some other data suggests we really have a bimodal distribution now with a lower age group kind of in the 30 to 49 age range, and then kind of the more classic kind of baby boomer or older group as they're moving through. So there are some maybe discrepancies in this data compared to some other data we have. It's still compared to others, tends to be mostly among whites and blacks. And then it disproportionately affects those that are on either public health insurance, so Medicaid, or are uninsured and are below the poverty level. What I just draw your attention to down here is that we've really seen no movement from the prior NHANES data, despite this encompassing availability of DAAs. So the prevalence has remained the same and the actual number has actually gone up because of just increases in the population. The last thing to point out here, some other analyses have tried to encompass other populations that are missed by NHANES. As they kind of say, NHANES is kind of a door-to-door survey, has a component of that. So if you don't have a door, you might not be counted. So persons experiencing homelessness are often missed. It doesn't cover persons that are justice involved or certainly not in prisons or jails are not necessarily counted. And then it probably just doesn't do a good job in general encompassing some of these vulnerable populations. So updated analyses here kind of take the updated NHANES data and then look at kind of NHANES Plus, which tries to get at prisoners, those in the VA and other areas that are not counted. And then if you really try to think more about other vulnerable populations that wouldn't be counted, you can see the estimate could be as high as 4 million persons currently living in the United States with viremic hepatitis C infection. And then just another thing to think about as we talk about elimination is what age groups maybe need to be targeted. These are incident cases, so this is really one of the metric that we're primarily looking at for elimination. And you can see the younger age group here, 20 to 29 anyway, we've seen a decrease over the last several years. That appears to be real and presumably might be due to better messaging about risks related to acquisition of hepatitis C. Maybe treatment is causing some of this decrease, but we still see pretty high levels in the next age range, 30 to 39, in terms of incident infection that actually seems to be going up, and those that are 40 to 49. I think this is the last real detailed US data in terms of current incidence. So this is from the CDC viral hepatitis report. The most recent report came out in 2024 that reflected the year 2022. And what you can see is, unfortunately, we've had a continued trend that actually goes back further. If you go back to 2010, we've had increases since 2010 in incidence in the United States, at least up till 2021. And what you can see here is a steady increase in incidence of hepatitis C, maybe a slight decrease. This is the first time we've seen this in over a decade, from 2021 to 2022. It was a pretty slight decrease, 6% as a percentage. And I think we at least need to see another year of this continued trend before I would be confident that that's a true decrease. I always like to highlight too, this is the estimated number of new or incident hepatitis C infections, so 67,000. But if you look at the confidence interval around this, it's huge. It could be as low as 53,000, but as high as over 200,000. That's due again to the fact that hepatitis C is generally asymptomatic in acute infection. And so what the CDC does is relies on the reported cases and essentially has a multiplication factor to estimate the number of actual acute infections. We know there's a lot of uncertainty in that number, however. And then we continue obviously to identify chronic infections as well, with hopefully expanded and universal screening. So if you remember, another component of the hepatitis C elimination goals for 2030 was to decrease mortality related to hepatitis C by 65%. And I will say here, we are starting to see a positive impact of DAAs in terms of hepatitis C related mortality. So developing cirrhosis, decompensated liver disease, or hepatocellular carcinoma. And I put here, this is recent data from the CDC, looking at DAA introduction late in 2013. And what you can see is hospitalizations related to hepatitis C have steadily come down over the next 5 to 6 years. And I think this makes sense. You know, certainly early on, DAAs were prioritized in folks who were already in care. Many had been treated with interferon regimens and failed, and already had established significant liver disease or cirrhosis. So they were really prioritized and were heavily treated early. And we know there's a pretty rapid impact, clinical benefit for those with more advanced disease of treating and curing their hepatitis C. And if we try to look at where we stand with the cure cascade right now, this is one of the most recent assessments nationwide using nationwide viral data from Quest, but that was done by Carolyn Wester and folks at the CDC. So if you estimate the number ever infected, this is maybe a little bit of a low number. About 90% roughly have had testing. So we're getting close to that threshold, maybe in that sense. For elimination, I think that's probably an overestimate, though. These are generally tend to be folks in care who are getting testing. Of those, about 70% seem to have an initial viremic infection. And then from there, you can see that their estimate is roughly a third have been treated of those that are identified with an initial infection. Again, I think that's probably an optimistic number. If we look at some of the other data trying to include high risk or vulnerable populations, it probably would dilute that down significantly, and it may be closer to 20%, but this is one estimate. And then of those, the vast majority are cured, but some may either fail or have reinfections. And then if you kind of take a scorecard for where we are in 2023 status, this scorecard kind of encompasses A, B, and C, but we'll just focus on C. So we certainly are not making these reductions in incidence goals, and this is a very a goal below what is set. So this is only 20% reduction in incidence. Of course, it is earlier by 2025. But as I just showed you, incidence tends to be up or maybe flat or slightly decreasing over the last year, but certainly no evidence that we're making progress toward to see a 20% reduction in a year. And then you can look at other things. Reducing hepatitis C related deaths, as I kind of showed you in this graphic, we certainly are past 25%. This was about a 35, almost 40% reduction just in those four or 5 years. So we are on track for this goal, not necessarily the 65% reduction. And then this just looks at some vulnerable populations or high prevalence populations where we're really not on track to see reductions in most of those groups. Okay, so now we're going to talk about the hepatitis C elimination puzzle and what are the aspects we really need to focus on and talk about some unique things to eliminate hepatitis C. I'm going to spend some time first talking about diagnosis and screening. We talked about that there's not a symptomatic or easily clinical identification of hepatitis C, so you need to rely on testing because most are asymptomatic. We've had universal screening now for a while. It was recommended in 2020. Just want to remind everybody this is here. So really, any adult should be screened for hepatitis C at least once in their lives with an antibody test. If they remain to be at risk for hepatitis C infection, that screening should occur continually, probably annually if they're high risk, if not more frequently. Before that, we had birth cohort screening. So again, this was a move from 2012 on with birth cohort screening to in 2020, universal screening for all adults at least once. I want to talk about screening, particularly in women of childbearing potential or pregnant women. In fact, so I like to keep this study in. This data is a little bit older, but it just highlights that what we've been seeing over the years, and this presumably has continued to increase given what we know about hepatitis C incidence in the country in general, is over the time from 2011 to 2014, all women of childbearing potential, they saw about a 22% increase in diagnosis of hepatitis C. But if you look at women in high-risk states in Appalachia, this is Kentucky specifically, there was over a 200% increase in women of childbearing potential who were diagnosed with hepatitis C. And what that translated into in Kentucky was a 150% increase in testing of infants for hepatitis C over that time period. The vertical rate of hepatitis C transmission is about 5%. And so we're seeing this increase. So what about testing in pregnant women? When universal screening was recommended in 2020, part of that was to test women each time they present with a pregnancy. So for each pregnancy, they should be rescreened for hepatitis C. This was not immediately adopted by ACOG, but ACOG did about a year later in 2021 adopt that recommendation for universal screening during each pregnancy. And then more recently, there's really been, I think, some more action, some more backing in ACOG that's been more vocal about management or screening for hepatitis C. There was this kind of call to action when they came up with updated viral hepatitis management guidelines for pregnant women. And so I think we've seen some movement. We just had the AASLD, the annual liver meeting in San Diego. It wasn't enough time. It was just this past weekend to put things in, but there was some updated presentation there looking at, has there been an impact of these updated screening recommendations? And they could show some evidence in 2016, about 60% of pregnant women were screened for hepatitis C, and that had increased to about 71% by I think it was 2021 or 2019. I'm trying to remember the exact time, 2021, where now it was up to about 70%. So some movement, certainly still not near 100% that we'd like to see. So that's one population screening. Now I want to talk about what are some maybe innovative ways to do screening for hepatitis C to improve our identification of persons living with hep C that might, particularly in vulnerable populations. I present one here. This is the Detect C study partly because it's from my own institution and some folks here, Sarah Rowan and Jason Halkus, an ID physician and an ED physician, got a large NIH grant to look at doing ED-based screening for hepatitis C and looking at two different approaches. One would be screening everybody that comes through the emergency department for hepatitis C if they don't have a test on file. The other approach would be doing targeted screening, do some risk assessment, and if they have risk factors for hepatitis C, do a targeted screening. And you can see this was a huge study. They randomized 150,000 persons presenting to EDs in Baltimore, Denver, and Jackson, Mississippi. What you can see is if you did non-targeted testing, you identified more hep C infections, statistically more hep C infections. But what you can also see is really a pretty dismal progression through the cascade after that. So getting linked to care was only about 20%. And then from there, actually, it wasn't bad if folks actually could make it to that appointment. And that's maybe not surprising. That's worse than we would see in a clinic-based setting, but you're screening in an ED where people are coming in for other things and don't necessarily have a relationship, say, with the ED or continued follow-up. Also embedded within Detect C was another aim to look at peer navigation from the ED to help folks link to care versus just the standard, we're going to refer you, here's your referral, you're responsible for getting there and following up. And perhaps not surprisingly, but good to see and document that peer navigation resulted in significantly better linkage to care, and then from there progression through the cascade to achieving SVR. SVR was not a statistically significant difference, and this was an interim analysis of that point with more linkages events occurring after that. A topic that often comes up under screening and testing is our reflex tests for hepatitis C, and I'll explain what we mean by those, and then the new point of care tests that are available. So reflex testing, this I thought was a nice diagram from one of the recent meta-analyses looking at it. So the old standard non-reflex test means you come into a visit, somebody does a screening with a hepatitis C antibody, you leave. You get the result of the hep C antibody, oh, it's positive. We've got to bring you back in, at least to the lab, if not for another visit, now to order an RNA test and figure out if you really have viremic hepatitis C infection. And then from there, based on the results, if they're positive, we'll treat you. So what should really be everywhere now, there's really no reason to have this testing approach anymore. We should at least all be in an area where we have reflex testing, which means at the time you place the hep C antibody order and the blood is drawn, it goes to the lab, it's tested. If the antibody is positive, the lab automatically takes that aliquot that's left and does a hep C RNA test. No other order is needed from the physician, and the patient obviously doesn't need to come back for an additional visit or blood draw. And that's where we should be. And data from Quest nationally, a national reference laboratory showed that before of persons with a positive antibody, only about 40% were getting the RNA done if there wasn't reflex testing. They instituted their own reflex testing. 95% now had an RNA result. That's great. There's been a meta-analysis that also has looked at this, instituting reflex testing in other settings. The meta-analysis, the same conclusion, statistically significantly more likely to get RNA testing done if you have reflex testing. But how much further down the cascade does that take us? There's really not much evidence that it really helps you beyond getting that verified RNA positivity. In other words, it doesn't necessarily help getting folks linked to care and or treated. Because typically that RNA result is still not coming back at the time you're initially with the patient. And so one, there's not an opportunity to communicate right there with them face-to-face. You have RNA positivity, we need to get you into treatment. It requires follow-up still with the patient. And again, there's not a lot of evidence that it does a significant impact to get you further down the cascade. So what about point of care testing? There was a recent JID supplement that kind of went all through all aspects of point of care testing and where we are with hepatitis C. And I like the way they framed this because really what we have just seen approved, and I'll talk about that in the next couple of slides, is a near point of care test, if you will. It still requires a pretty expensive machine. You have to have electricity to plug it in, cartridges, and some very minimal, but still some maybe processing of the sample. So it's not what I would think most would define as a true point of care test. And they go here to define true point of care is something that's portable, maybe could be battery powered, does not really need any specialized lab processing or other things, and is fully automated. And then the holy grail is kind of what they called instrument-free point of care. And now you're thinking about like our at-home rapid COVID-19 tests or home pregnancy tests where it's no power is required for this. Maybe even the person themselves could do the testing. Doesn't require any specialized equipment and is very easy to read. And we are not there yet. Folks are trying to really develop these two areas of test, but that's not really where we are right now. And then just to finish this out, some other potential issues with point of care testing. There are other labs we generally need before we start treatment. So you could get the point of care hep C RNA result. Is that enough to let you just go ahead and start somebody that day? And then you would need medications readily available, and we'll talk about some issues still with medication restrictions. But here it is, the first kind of announcement recently this summer of a point-of-care hepatitis C RNA test. This is evidence of the machine, so you can see, again, significant space required, needs to be plugged in, has these cartridges, can be done off a finger stick, so there's really not a lot of other lab collection or processing that needs to be done. You put the cartridge in, and it's self-contained and kind of runs and gives you a result. So how might this be implemented? There are lots of studies that have looked at this. This is one I just picked out from a more recent study. This is from Australia, the PROMPT study, excuse me. It was an interventional cohort. Now this was done in kind of specialized settings. In other words, these were settings where the patients were going to be around. It was prison intake, alcohol and substance use treatment, inpatient unit, or an inpatient mental health unit. So again, you could screen these folks, but then they were going to be on the unit and around, so you could bring them back then to do treatment. And this was their process. So they initially did a rapid point-of-care antibody test, which could get results within 5 to 20 minutes. And with all these tests, if the test is positive, it typically turns positive pretty quickly. So if you're somebody who's going to be antibody positive, they're often positive pretty early, like closer to the 5 minutes, whereas if it's going to be a negative test, it's where you need to wait till the end of the time period. But if they had a positive antibody, They were approached about doing a rapid point-of-care test. And again, this was the same test we just outlined, which takes roughly 60 minutes. Again, if you get a positive result, it could be a little sooner. And during that time, they're doing other things, counseling, talking about hepatitis C education. And then if they were detected, they gave the results right there, but they didn't start treatment at that time, but they arranged them to come back for treatment. They clearly showed that patients like this. They were more likely to get tested if they knew they could get an immediate RNA result, and they had higher satisfaction. And then they did look compared to historical controls within these same institutions, and they certainly showed significantly increased rates of treatment uptake, 95% in the prison and 67% in the inpatient units, relatively small numbers. But so they could show that this actually did impact DAA treatment uptake. So for time, we're going to move on, try to address some of these other areas. We can come back to the questions in terms of diagnosis and screening. So what about DAA treatment access? First, I think everybody here probably knows this, but we have excellent treatments for hepatitis C in 2024. Particularly glecaprevir-pibrentasvir, which is a fixed-dose combination, and sofosbuvir-velpatasvir, another fixed-dose combination. These are pangenotypic regimens, which generally have a pretty standard duration for most patients. You're going to talk about 8 weeks for GLP and 12 weeks for Sofvel. Efficacy is great, as I put here, lights out efficacy in the real world. These are 2 Italian cohorts looking at, again, glecaprevir-pibrentasvir and Sofvel. SVR rates are really in the range of 98 to 99% for both these regimens. Again, with the recent AASLD meeting, some could say, well, this is in kind of high resource areas where they have lots of capability. What about how do these DAs perform in other areas? If we start talking about elimination globally in low and middle income countries. And so there was at AASLD this SVR 10K study that was presented looking at treatment specifically in some other areas from Southeast Asia, South America, Mexico. And the moral of the story is they seem to work just as well in these areas. They were getting SVR rates just like these 98, 99% from that 10K study at AASLD this year. And based on the availability of these great treatments, we have multiple simplified guidelines that outline how to approach this. So the AASLD IDSA has a simplified set of guidelines. They have 2 different guidelines, one for those without cirrhosis and one for those with cirrhosis. For persons living with HIV, we spent time updating the DHHS OI guidelines pertaining to hepatitis C and outlining a simplified approach, which looks very similar. I won't walk you through the details of these. It's more important just that they're out there. Both the simplified approaches rely on using these pangenotypic regimens because presumably or certainly it's not a requirement that you have genotype available, particularly for a treatment-naive, non-cirrhotic patient you're looking at treating. The genotype is not going to make any difference in how you approach their treatment. And this has actually been studied in the real world. The ACTG MinMon study, A5360, that was led by Sunil Solomon at Johns Hopkins, looked at implementing a minimal monitoring treatment approach. It was done across the globe in the United States, Brazil, South Africa, Uganda, and places and locations in Thailand. It included persons living with HIV, about 40% of the group. Persons with cirrhosis were eligible just using a FIB4, which you can use based on just age, ALT, AST, and platelets. You can come up with a number and assess whether somebody might have cirrhosis, but it doesn't preclude you from using a simplified approach. And then this was the actual MinMon approach. So no genotype was available at baseline. You essentially confirmed viremic hepatitis C infection and got the basic labs to calculate a FIB4. Patients were given the entire supply of Sofvel-Velpatasvir, so the 12-week supply. There were no in-person follow-ups. There was a phone call at week 4 to just kind of check in, say how you doing, everything going okay, and then a check-in at week 22 just as a reminder to come back and get testing done for SVR12. And these are the overall results, 95% SVR12. I won't go into a lot of other details. The unique subtypes, genotypes is not important. We did at CROI last year, or this year, I guess, in Denver in 2024, have an updated analysis that looked at sequencing and took into account, essentially allowed us to take these 17 recurrences and figure out were some of those reinfections. And if you counted reinfections as actually successful treatments because you got rid of the original infection, the SVR rate actually was up to 97%. So again, with a minimal monitoring approach, treatments seem to work just as well. So what are other things we can do to improve medication access? One would be easing restrictions, right? Simple, duh. And this is just some Medicaid data looking at that. The orange bar are states that did not ease restrictions. You still see an increase in treatments as they become folks are more comfortable with them. There's increased awareness. But in states that eased Medicaid restrictions, a dramatic increase that was significantly higher than those states that did not ease restrictions on prescribing. And then if you look in detail at what's eased, I thought it was kind of interesting. The big ones are if you ease fibrosis restrictions and prescriber restrictions, and we'll come to that in the next slide. That had a significant impact, whereas sobriety restrictions, at least in this analysis, didn't really seem to move the needle in terms of treating. So when I talk about restrictions, this is something that folks that are used to dealing with hepatitis C are kind of well aware of, but everybody may not be. So starting with the availability of DAAs around 2014, 2015, the folks at Harvard and the Center for Health Law and Policy Innovation started developing this state of hepatitis C map, where they would have the US map, they'd color code states based on how well they were with access to DAAs. And this encompassed, do they have fibrosis stage restrictions? Do they have sobriety restrictions? And what are they like? Do you have to actually test? Do drug testing to see if somebody might be using substances? Do you take word? Can they still be treated? Do they have to have counseling? All those kind of things. Do medications need to be prescribed by a specialist? Can they be prescribed by anyone in consultation with a specialist, or can anyone just prescribe them? Things like that. And so I just showed one snapshot here in 2017. Not great. A lot of dark D's and F's here. This is percentage-wise how it breaks down. So a lot of states were bad. I'll draw your attention specifically to Louisiana because we'll come back to this. So they were graded as an F in 2017. And here's where we are in 2024 this past month. Nobody's at a D or an F. Most states, actually over half, are now at an A. You can hover over any state. I hovered over mine, Colorado. We actually get an A+. What you need to have to get an A+ is actually removal of prior authorizations. And we've had that now for almost 2 years, where there's now even no prior authorization for folks under Medicaid to access Hep C therapy. Anybody can prescribe it. You don't need to provide any lab testing, anything. You just write it like you would any other prescription. And so there are still states that do not have that. That's generally the other ones that have A's, but not A+. So is coverage for DAAs enough? Well, no, it's not. This is some data looking at just starting within a year and based on what insurance you have. And certainly there's a trend towards those with private insurance initiating DAAs within the year at a higher rate than those who are under Medicare or Medicaid. Some of that may be restrictions in coverage, but some of it is probably due to the populations that tend to have these different types of insurances and other barriers they may be facing. And that was this other analysis that kind of highlighted some of those. So these were all Medicaid enrollees. They had been on Medicaid for at least 60 days before they did this analysis and had coverage for a year after it. And they looked at who started treatment after their diagnosis within 6 months. And what you see is younger folks were less likely to start. Persons with injection drug use were less likely to start, or alcohol use disorder or mental health disorders. So again, this is presumably not due to Medicaid coverage. This is due to these other factors that are presenting other barriers, whether that is perceptions of treaters and thinking they cannot treat some of these populations or they can't do it safely, or just logistical barriers in our system that make it harder for folks in these groups to access therapy. You'll hear a lot about this, so I thought it was worth covering. What about subscription models, aka the Netflix model? And we've seen some states do this, notably Washington and Louisiana. I remember I asked you to remember Louisiana in 2017, got a grade F for access. So this is where the state enters into agreement with one of the manufacturers of hepatitis C DAAs and either pays a fixed rate for unlimited access or continues to pay up to a certain point. And then if they hit a number above that number of treatments, then they get unrestricted access above a certain number of treatments. And this just looked at both modeling scenarios, and then the solid lines are what actually happened in these two states. And here in the shaded gray is when they entered into these subscription models. And what you can see is there's very different things happen. Washington state always had great access. There were really no restrictions. And so when they entered the subscription model, it really didn't change their rates of treatment at all, because that wasn't the issue with getting folks treated. Whereas in Louisiana, it was extremely restricted, fibrosis stage, prescriber restrictions, and everything else. And after you opened up, you saw a huge increase over the next couple of years, although that was not really sustained and comes back down. So again, none of these things in isolation work. It's a comprehensive model that needs to address the testing, the linkage, identification, as well as the medication access. What about reservations for treating maybe vulnerable populations? Because people say, I have concerns they won't take their medications or their adherence won't be great. And I just point out these two studies, Simplify and Hero, both used Soft-Vel for 12 weeks. And I just think these plots are kind of really telling. So across this way in the rows is an individual patient. Each line in the column is a day of therapy. So this is 84 columns here, 84 here. And so what you can see in darker colors means these were blister packs, means they took their dose that day. The lighter color means they skipped it that day. And this they arranged this one from best adherence to worst, and you can see some trends. Obviously, going down in adherence, but even through time, even for the best adherence, you see people get a little worse as they go. And over here, these lines in black for this one are the ones who did not obtain SVR. And what you see is, sure, more SVRs as you get worse and worse, but still very high rates of SVRs until you get down to somewhere around below 50% adherence where it really starts to drop off. Shown another way, this is again from the HERO study. What you can see here is this is the number of days out of the 84 days prescribed they took. And you can see no real significant drop off in SVR till you get really somewhere below taking half the medication. The dark blue here is a per protocol analysis. So they followed them and they actually came back for an SVR result and it was tested. The lighter blue is a modified intention to treat, where if they didn't come back, they were counted as failures. So if they didn't have testing, they were counted as failures. And they were in the modified intention to treat so long as they at least took a week of medication or had a week of blister pack data. Another way you can look at it is what was the largest gap at any point in time in their therapy. And again, you can see if you stay with between 1 to 2 week gap, you still have pretty high SVR rates, around 90% in the per protocol analysis. Once you get over missing more than 2 weeks in a row, then you really start to see it drop. But I think the moral of the story is here, we shouldn't be avoiding prescribing DAAs to patients or persons living with hepatitis C based on our perceptions of how adherent they might or might not be, because one, they're very likely to succeed anyway, and we don't want that to be a barrier. Okay, I'm gonna have to probably speed up a little bit. I'm talking too much here, but a next key to the component is access and outreach. Meeting people where they are. So I come back to the HERO study because this was a study that really looked at a unique model, one of the first studies to do this, delivering hepatitis C therapy outside the clinic, essentially. So they went out into opioid use treatment programs or community health centers, so not a specialized referral center. These were all persons who had active injection drug use within the last 3 months. They were all treated with Soft-Vel, as we said. And they got either modified directly observed therapy, essentially 5 days a week when they would come in for their Suboxone or Methadone. They would also get their Hep C therapy observed. Weekends, they would do it on their own. And then patient navigation, again, is the standard. From these centers, they're referred to some place to get their hepatitis C treatment done. But you can see overall 92% SVR rate and per protocol. Adherence wasn't actually markedly different, although they had a very robust navigation system in place. And then you can just follow them through the cascade here, and you can see of those enrolled, about 20% were lost before and didn't initiate. And then another 20% or so are lost as they don't complete therapy, and then testing for SVR. This doesn't mean this is the actual SVR rate. This is what's confirmed by testing. So if you didn't have a test result, it didn't count. You were counted as a failure. So that's one way. I'm going to just highlight a program we have here at Denver Health that's led by Sarah Rowan. This is kind of her own picture. She drew these of how this works, but this is integrating hepatitis C treatment in syringe services programs. So clients come into SSPs for other supplies. If they report a history of hepatitis C or want hepatitis C testing, they're immediately set up with a telehealth visit that we do in essentially real time. So Sarah or I are kind of on the whole time during the week for our navigators to let us know, hey, we've got somebody at the SSP. Can you hop on a video visit with them? They do phlebotomy on site, bring it back here for centralized testing. And then if they do have hepatitis C, because of no prior authorizations, if they have Medicaid coverage, it's very easy. We prescribe the medications. They're delivered back to the SSP, where then the client, when they come back, can pick up the medications and have their treatment delivered there. And then we can draw blood on site again. We've moved to SVR4. We find just the shorter time periods, it's easier to kind of get outcomes. But and SVR4 is a very good surrogate for SVR12. It's not perfect, but about 98% of the time it's concordant. And so that's the process. And so at the recent International Network on Health and Hepatitis and Substance Use, users meeting that was in Greece. Sarah presented this. This is just kind of monthly, the number of visits we had. So 85 participants, most had recent injection drug use. You can see the age here. Most on Medicaid, 91%. And this is kind of the cascade. So of the 58 that were RNA positive, 54 out of 58 started treatment. So that's a very high rate really for the vulnerable populations we're talking about here. We do have some loss in terms of completion of treatment. Some are still in treatment follow-up and then SVR rate. So again, at least much better at delivering this than having them start treatment. And even if they don't come back, remember, if they took most of their medication, they're likely to be cured anyway, even if we can't verify that. And then in this coming year, we are going to have one of those Cepheid machines on site there and be figuring out how we integrate that, if we can have medications on site to have them essentially start while they're there, and things like that. But we're going to be integrating point of care testing. The last two places I'll talk about other outreach is one, inpatient admission. So this was a study that was recently in CID from Oslo, Norway, where they took inpatients. They were tested. If they were positive, they had a group that would come meet with them, get medications approved, and deliver therapy inpatient to start treatment. They could show that they had significantly higher DAA rate starting than just identifying them and referring them to outpatient therapy. About 70% started if they started inpatient, whereas if they were referred, it was about 35%. So they were much more likely to initiate treatment. Interestingly, to have documented SVR and testing, they actually couldn't show a difference. So you did lose some of those who started inpatient in that they didn't come back to have SVR tested. But again, presumably some of those are cured despite not coming back for testing. And Sarah and I did a little editorial about this. It's something we've been interested in at Denver Health, but just the nature of Medicaid and how typically they're bundled payments for admissions. And while somebody's admitted, you could not submit a script that would go under outpatient Medicaid at the same time. That's considered double dipping. And otherwise, if you treated them inpatient and started their medications, that cost would go into their bundled payment for their admission. And so, it's just not financially possible in most settings. I know some institutions maybe kind of get away around this. Our lawyers here have really told us it's really not an option. If it was scrutinized, it could be a significant liability for the institution. So that's where we had a nationalized system where Hep C medicines were a carve out and they're just covered for everybody under Medicaid without regard to inpatient versus outpatient would be a great opportunity. And we certainly could identify a lot of folks that we could start treatment on inpatient. I've mentioned pregnancy before. Treatment during pregnancy is still a work in progress. I just want to highlight Catherine Chappell had a talk at ID Week this year highlighting some of the pros for treating it, particularly for women who have substance use disorder or other experiencing unstable housing, other vulnerabilities. Pregnancy is a time where they're really integrated into the healthcare system, have better coverage, and are engaged in care, and is really a unique opportunity for some high-risk patients to engage them in treatment. There are still some questions about Hep C treatment during pregnancy. Animal data suggests it would be safe, and we have about 52 women now that have been treated in Catherine's studies, HIP-1, HIP-2, and STORK, and it looks completely safe, and all women were cured. This was interesting too, from Dr. McCrary at Washington U as an ID physician. Their group was looking at inpatient consults again. They're tested when they're in for labor and delivery, and they actually deliver medicines to women during labor and delivery to start in the postpartum period. I think that's another unique opportunity. Again, I could see there are potentially issues with how the DAs are paid for. If they're currently inpatient, in theory, you really can't charge them to Medicaid outpatient. But another unique thought about how we can improve delivery. Okay, the last two things here in the last 5 minutes. Harm reduction and prevention, another key for hepatitis C elimination. And I want to do this in the context of some special populations. One I want to talk about are persons living with HIV and the issue of reinfection. So this is from the NEAT network in Europe, where they looked at persons living with HIV who were diagnosed with Hep C and either acute Hep C and either spontaneously cleared or were treated. And they looked at subsequent reinfection rates. And what you can see here, by 5 years, about 25% had been reinfected. That correlated to 7.3 per 100 reinfections per 100 patient years. And then within that subset, there's a very high-risk group that had multiple reinfections. And you can see here with a second reinfection, the incidence went up to almost 19 per 100 person years. So very high. And almost all these were HIV, persons living with HIV who were men who have sex with men. If I summarize kind of some other studies, the GECKO cohort is a German cohort, again, of MSM, almost all living with HIV, who had a reinfection rate of 9 per 100 person years. If If you contrast that to persons with injection drug use, maybe 6, some cohorts have been lower. And then if you look at persons with a history of injection drug use who are on opiate agonist therapy, it drops it down even further to about 4. So persons living with HIV, particularly MSM living with HIV, seem to be the highest reinfection risk group. Although again, there's obviously variability between the different cohorts. This is one of Daniel Fear's cohorts in New York City where it was a little lower at 4.4. A recent meta-analysis also looked at this among persons with HIV and reinfection risk. And indeed, men who have sex with men living with HIV were the highest group in this meta-analysis across all studies for reinfection. They found a rate of about 6 in MSM compared to PWIDs where it was around 3. So what can DAAs do in some special populations as we think about microelimination? So this was in the in-check cohort, which is across Europe, just looking at across different periods, HCV incidence has certainly dropped with the advent of DAAs. You can see it look pretty stable in persons living with HIV in these cohorts, which are generally in Australia, Canada, and Western Europe. And then with the availability of DAAs, we see this drop in incidence. This represented about a 35–40% drop in incidence, so wouldn't meet elimination criteria. And then what about reinfection incidence? That also was seen to drop, although not quite as fast or to a same level. But again, reinfection 1 being higher than initial infection, and then about a 30% drop with broad DAA access. This is another way to look at it. Of all infections, initially, most are initial infections. This green bar are reinfections. These are second reinfections, third reinfections. As we go through time and start treating populations, reinfections make up a bigger proportion of all incidence infections. And even here, you can see with continued DAA treatment, you're dropping initial infections, but we weren't really seeing this green bar get much smaller. So reinfections really weren't being impacted as much, maybe till this last year. And then in the Swiss HIV cohort and cohorts in the Netherlands of persons living with HIV, they've had really great programs where they essentially test everybody in their cohort with RNA, roll out DAAs to everybody. And what you can see are dramatic drops in prevalence over time. So prevalence is kind of here, 4.8% to 1.2 to 0.6, with massive treatment, retesting, and retreatment. This is a Swiss HIV cohort. But what you see here, these lighter blue bars would be the incident infections, and there's a drop, but it's about a drop of 50%, not a drop, in the order of 70 to 80%. So again, incidence seems to be a little harder to get to drop, certainly harder to get to drop than prevalence. Finally, despite this, and this is from Amsterdam, what they saw is if they looked at phylogenetics, despite seeing large drops, they continue to see incident infections, and it actually seems to be the same strains of hepatitis C that were present prior to YDA rollout and in the same populations. And in particular here, looking at MSM, what you see is not only mixing among HIV positive MSM, but you see HIV negative MSM, not serosorting, so to speak. And so you're seeing transmission between, not by HIV serostatus, but by MSM. And then these are just 2 other cohorts that I think I'll skip over in the interest of time, just suggesting we're making inroads. A live cohort is PWIDs in Baltimore, and then the CEASE cohort is persons with HIV in Australia, where again, as DA rollout has been there, you're seeing decreases in prevalence, but hepatitis C being just tougher to decrease than HIV and not going completely down to levels we'd like to see for elimination. I want to talk about vaccine in one slide, and that is with the work now being done on controlled human infection models. So I think this is where we are with vaccines. I just want to make folks aware that it's out there. So this is where you would actually study folks, they agree to be infected with hepatitis C, and you actually study a vaccine in the setting of a controlled infection. None of these are ongoing. There's a lot of work with the NIH and various thought leaders about how these would proceed, but is really probably what we need to move the needle on vaccine development for Hep C. I think long-acting injectables are what we're going to have first and maybe could be looked at as a vaccine. This was from Croy in 2024 in Denver. At this point, we're just in a mouse model. This is with glecaprevir pibrentasvir, which appears to be the formulation that's kind of most well-suited to potentially making a long-acting injectable. These were mouse thigh models, but what you can see is with a single injection here, certainly maintaining levels of, in this case, it's glecaprevir, the protease inhibitor, but this is pibrentasvir, the NS5A inhibitor, well above the analogous troughs with oral medications we currently have for past the 8-week time point of our current treatment regimens, and in fact, for some, well beyond. So I think this is hopefully on the horizon. There are no human studies underway yet. Formulations are still being worked out, but I think this is something that could really still be a game changer and could perhaps act like a vaccine as we move forward. And we can talk more about that in the questions. So the last topic here, just in the last couple minutes, is political and social will. And to just give the kind of punchline, this is what's really needed. And as I highlight success stories, this has been the factor that has really pushed those countries that have made significant progress on elimination over the line. We'll talk briefly about the country of Georgia and Egypt in particular as highlights. They've had government involved, funded, and supporting national campaigns. And unfortunately, this is something that I think is going to be a real problem in the United States, and I just don't see happening. The Biden-Harris administration did put out their tentative plan that included accelerating use of point-of-care tests, improved access to DAAs, all the stuff we've talked about, and public health initiatives. The Congressional Budget Office also came up with their analysis of the costs of increasing treatments by 10% or 100%. They thought it would take 5 years, 2 years to ramp up peak treatments in the third year and then start to decline. The costs were $500 million to $4 billion, but then the savings you would get on 10 or 100% were 0.7 or 7 billion in savings. So it appeared to be cost effective or cost saving. But again, are we going to get that now going forward? It seems unlikely we'll get a national plan to me. So what are the success stories here? I already mentioned the country of Georgia. They had a pretty high prevalence of 5%. They undertook a national campaign. You can just look at this. This is the total number they screened over the campaign from 2015 to 2024. 2.5 million persons screened. Of those screened, if they were confirmed to have RNA, this is the travel down the cascade. Some drop off, but they managed decreasing the prevalence from 5.4 to 1.8%. They expanded testing, including using hepatitis C antigen. They offer services widely dispersed throughout the communities and had access essentially for everybody to medications. And these matched or exceeded modeling predictions of where they would be. And they're on track pretty close to elimination by 2030. I want to highlight at least one positive, the VA at the United States. Again, this is a kind of an integrated, closed medical system where DAs were available to everybody. Everybody could get testing. And the VA's done an amazing job. They estimated they had 140,000. Of those, they got 93% tested, 80% on therapy, and 92% of those were treated and cured. Cherokee Nation had a program. They did well in getting diagnosis, essentially, from everybody and linking everybody to care. One of the problems is they're still reliant on Medicaid restrictions, and at that time, Oklahoma had some significant restrictions, and that really impacted initiating treatment and getting SVR12, but still a good effort there, I will say. And then just to finish, the success story is Egypt. They had the highest prevalence in the world, estimated around 10% of hepatitis C, and they embarked on a massive national campaign. Mass media had online availability where you could register for a test. They had testing sites at public transportation throughout all the major metropolitan areas. You can see here almost 5,000 testing sites. You registered, you got your test, the result came in. If it was positive, that same registration allowed you to book an appointment to go get your medications and start treatment. And what they managed to do is treating Hep C. You can see here in the interferon era, we're treating 50,000 a year, started with DAAs. They had access to generic DAAs where they could get a course of treatment for about $50 US. And you can see here, the biggest treatment was in 2019, treated 1.5 million. All told, they treated over 4 million persons and converted prevalence of hepatitis C in Egypt from 6% to down to less than 0.4%. And they are on track or have already really almost come close to meeting elimination goals and got a recognition by the WHO as the first country to do that. And now are trying to help other areas in Africa so you don't get reinfections. And this is just the scorecard. Those in green are on track to eliminate by 2030. The United States, we're way down here at the bottom, not on track to eliminate hepatitis C even past 2050. And this is just another graphic to show who's on track and who's not, another way to look at it. So in summary, steady progress is being made on Hep C elimination, some places more than others. It is highly variable by geographic locations and what populations you're talking about, and maybe micro eliminations like in persons living with HIV in the Swiss cohort. Core concepts are the same, all the things we talked about: testing, access, political will. But the problem is, for the specific population area you're talking about, the solutions under those different broad categories are highly variable, and you need different approaches in different places. So it's not a one size fits all. And certainly we're not on track in the United States to meet those elimination goals. All right, we're going to come back to the questions. So post-test question 1, what percentage of hepatitis C incidence decrease is the target for elimination by 2030, again, set out by the WHO? 50% decrease in incidence, 80, 90, or 100%? We'll see what the answers are here. Okay, good. I think we saw some movement. So most of you got the 80%. 80% is correct. Again, it's a little confusing because the overall WHO mandate, which included B and C, says 90% overall, but remember that's different for B and C was actually an 80% decrease. And then let's go on to the next question. Now, here's the answer for that. I think I went through that. Okay, post question 2, hepatitis C reinfection rates after successful direct-acting antiviral therapy are highest in which of the following groups? So persons living with cirrhosis, persons who inject drugs on opioid agonist therapy, men who have sex, men with HIV who have sex with men, and cisgender women who have HIV. Answers look like here. Okay, great. This is definitely one. The first time around, the majority, the most popular answer was actually B, persons who inject drugs, and that makes sense given what we know generally about hepatitis C transmission. But again, and clearly now with 73% of you getting men who have sex with men who also are living with HIV infection is the group that pretty consistently, including meta-analysis, have been shown to have the highest rates of reinfection. Okay, and with that, I think we're done and we're ready for questions and answers.
All right. Thank you for that terrific talk. And we have a number of questions and a few that are focused on that key population you identified of persons who inject drugs and meeting them where they are and integrating care at syringe service programs. One question related to the population is, do you avoid using glecaprevir pibrentasvir in those with active opioid use disorder and using unregulated fentanyl, considering the theoretical potential for a little increased fentanyl exposure?
Yeah.
Drug interactions.
Yeah, we have not at all, Kara. And I mean, I think it's theoretical, and I can't say that there were actually at AASLD there was another study looking at GP use in folks on a lot of different medications that might have minor interactions, and really no evidence that there was any decrement in efficacy. Of course, with fentanyl, the concern could be, could you precipitate, I suppose, an overdose? But we have not seen any indication of that. And I'm not aware of anybody treating that avoids that combination. The only other thing I'll say about GP, there are some studies, including an ACDG study, looking at short duration, 4 weeks. And that is the one, you're not at the 98% treatment with 4 weeks, but you are 80, 85%. That's the one that I think you can probably get away with the shortest amount and have a pretty good SVR still. So I think there's a lot of reasons for that to be attractive. In addition, is a lower pill burden more important or shorter duration? I tend to find shorter duration for most, but not all patients is the thing they prefer.
All right. And then in your SSP outreach-based treatment program, did you dispense the full treatment course all at once?
Yes, they do get the full treatment course, but they can also have it held there. So if clients don't want or can't take it with them or are scared they're going to lose it or get it stolen, they can keep whatever portion they want there and take the rest with them. So, and I don't know if folks know, but GP, in the way it comes, it's this big box that's got 4 little boxes in it for each month. So you got 2 big boxes, and then there's another box for each week. So a lot of times they'll take 1 week with them and then come back to get it. Soft Vel tends to come in bottles that have 28 pills in, so it's 3 bottles, but we do dispense it all at once, at least if they're straight up Colorado Medicaid, and then they can decide how much they want to take with them.
And in your experience, did you see any difference in SVR rates in those with or without HIV in that in your program at the Syringe Service Program?
In the SSPs, no, we haven't seen any difference, and that's in line in general with you know, all the clinical trial data, which really shows no impact of persons living with HIV and a decrement on SVR.
Okay, and then from Robin Frank. So Robin's clinic has only used Sofvel, sofosbuvir hepatitis. And what are the medications used in the simplified approach? And in their experience, Sofvel requires many labs and prior authorization, which perhaps limits their opportunity to rapidly initiate.
Yeah. So the simplified approaches and the algorithms from ASLD, IDSA, or DHHS for persons living with HIV have both those as options. So it would be glecaprevir, pibrentasvir, or sofosbuvir, velpatasvir. So they're both options from that standpoint. There's really no difference there. In terms of prior authorizations, yeah, you know, that's clearly a limitation, and it really is going to depend on where you practice and, for instance, your state Medicaid. So in Colorado Medicaid, both those regimens are on their list as options and don't require prior authorization for either one. So yeah, unfortunately, that's going to be a local limitation. There are not a lot of ways to get around that.
Yeah, and suppose perhaps related, just in terms of how to fund programs.
Yeah.
We received a couple questions about that. Do you have any suggestions, guidance?
So I guess my suggestions would be in terms of, there's several things that are helpful. One, if you have a dedicated pharmacy group that can help you navigate these things. So we're lucky enough to have pharmacy specialists and techs that will do prior auths if we have them or need them. Say somebody's under Medicare where you still need a prior auth, or they have private insurance where you almost always need a prior auth. They're also a great resource to get like copay cards and things like that. So those are widely available copay cards. If somebody has Medicare, but they're still coming back with a $3,000 copay, they can generally get that covered for you. The next steps are the pharmaceutical companies themselves actually tend to have pretty generous patient assistance programs, particularly for folks who don't have any insurance. They don't need to be documented or anything else. They really just need to provide a little evidence of, do they file a tax return, or what kind of income they might have. If they say nothing and they don't have any insurance, they'll provide therapy generally for free, and doesn't matter if they're undocumented or newcomers. The last funding source that, at least for us, has been helpful has been the state health department. So Colorado Public Health and Epidemiology, for instance, they're funding the SSP program right now. In terms of kind of the outreach, they don't fund the medications, but they fund the other support. And they're the ones also funding the point of care RNA test for the next year. They're providing that. So I would align with your state health departments, I guess, would be the next thing, county and or state, depending on how it works where you're practicing.
Okay, and then a couple questions related to Hep B screening. So there's that potential tiny risk for Hep B reactivation with Hep C treatment. Do you feel like Hep B surface antigen screening is necessary, is essential prior to initiating Hep C treatment, or does it really end up being a barrier to testing and treating? And then what have you observed to be the risk of reactivation in your SST program? Yeah.
So it potentially is a barrier if you kind of stick to the letter of the law, right? And that you need a surface antigen test before you start. I think practically there would be no risk in starting if you could get the surface antigen test even in a week or two, right? Because what we know, if somebody's going to flare their hepatitis B, and the highest risk is by far surface antigen positive persons, not isolated core who don't have surface antigen, that flare is months down the road if it's going to happen at all. And there even are some data with sofludipisphere, even in surface antigen positive patients, the risk of flare is pretty low, but it's not zero. We haven't seen any surface antigen positive in our SSP program that I can recall. And we do testing, right? We do phlebotomy and bring it back. And so we do central testing and get all that. And again, The most common scenario would be probably an isolated core positive, so prior exposure, either with surface antibody or just core, where that risk is extremely low and there's really nothing you need to do about that. But you know, others may have different opinions. Jason Grebley had a commentary on one of those point of care things, saying similar things, that really should not get in your way of rolling out this treatment. But yes, try to collect it and get it at some point so you know.
I like that as a strategy. A couple questions around reinfection. Is there any difference in the cure rate in the SVR12 rates after retreatment for reinfection versus primary infection?
No, there's not. If you can document reinfection, you treat them just as you would a treatment naive patient, right? That the virus is seeing the medication for the first time, if you will. So you don't need to use like soft Velvox or something like that. You can retreat them with the same standard. Really, you could even use a simplified approach again in that case, even though technically they've been treated before.
Mm-hmm. And I think we have time maybe just for a couple short questions.
Yeah.
How do you distinguish reinfection from relapse?
Yeah, it can sometimes be a challenge. So if they have a genotype switch, generally, I presume they didn't have a mixed infection. That would be rare, so that's a new. If you have SVR12 data, so you know somebody achieved SVR12 and then they're coming back later, particularly if they had ongoing risks and they have a new infection, I think you can safely assume essentially all the time that that's a reinfection. The rate of late relapse after that 12-week SVR is significantly less than 1%. The problem comes in somebody you treated that maybe didn't follow up, you never documented their SVR12. I think you're stuck treating them as relapses, so using something. There's really no practical way with lab testing. You could test and see if they have resistance mutations now, but that's not perfect. So that would be the ways I would distinguish.
Mm-hmm. Okay, and if you have time, just one more question.
Yeah, sure.
Is there a plan for the guidelines to move to SVR4 instead of SVR12 for cure determination?
So I've rotated off, so I'll plead ignorance, but I don't believe there's any plan. But like I alluded, about 75% of recurrences happen in those first 4 weeks. And then if you flip it around and say a person's getting SVR, if you have SVR4, about 98% of the time they go on to have SVR12.
And it's great to just get that testing done.
Yeah, you at least have a great indication that they're cured. It's not 100%, but it's close.
All right. Well, I think that's all we have time for today. Thank you guys so much. And just some additional information. You will be able to access information on how to claim your CME and other credits. This will be emailed by 5 p.m. PT tomorrow. And please complete the feedback evaluation survey. Check out the IAS-USA podcast, Going Antiviral, with Dr. Michael Sag. There was a recent Mpox podcast, and then also now one on cure for hepatitis B with Dr. Kenneth Sherman. On December 3rd, there's the annual IAS-USA DC virtual course. Please join if you can for that. And then also on December 4th, or close to that time, there will be an update on HIV primary care guidelines by Doctors Thompson and Johnson. CROI is coming up 2025 in San Francisco. That should be fun. Save those dates. And then finally, a conference on bacteriophages. David, that's close to you, in DC. I was thinking of your recent or your past UC San Diego connection. Yes. So save the date for that. That's a meeting in October 2025 in Washington, DC. Okay, thank you guys all for participating. Thanks, David, for a great talk.
Yep, thanks everybody.